Hi, everybody. Welcome. Thank you so much for letting me come and talk with you all. My name is Michelle G. I'm the Director of Business Development for Ohio Living, Home Health, Palliative, and Hospice. We provide services in the home and wherever you decide to call home. What I do is I work with a group who pretty much do care coordination for patients who are on our services or who are wanting to have home health, palliative, or hospice services. What we do is we really try to do our best to keep patients and families wherever they call home, in their home, whether it's at an AL facility, whether it's in a long-term care facility, or if they're in their own personal home. That's what we do, and we provide care, skilled care in those areas. We have a group that goes out and meets with patients. We have people who meet with them and try to coordinate care at the hospital setting. We work similar to like case managers, if you've ever worked with them before, and social workers to really make sure that patients are being taken care of. One of the things that I'm here to talk to you a little bit about is understanding what palliative and hospice care is. And I've been in home health or in the healthcare field for over 25 years. I've worked with Ohio Living for 6. And in the past, started out being an STNA in a nursing home and decided that healthcare was my passion. So I've just pretty much done the gamut. And so here I am today to share with you a little bit about what Ohio Living is about.
I'm Angie Rumor. I am the sales manager at Brooksdale Senior Living here in Bowling Green. We are an assisted living and memory care community, serving the Bowling Green and surrounding areas. And I'll just talk more about that when it's turn.
My name is Jennifer Wagner. I'm an associate practitioner professor in the gerontology program at BGSU. I primarily teach long-term care administration. I also have a second sort of part-time position at the university as the director of the Optimal Aging Institute. I am a licensed nursing home administrator in the state of Ohio. I'm also a certified assisted living administrator in the state of Ohio. For many years, I was a volunteer ombudsman, but because of another role that I do with the Ohio Nursing Home Administrator Licensure Board, I had to give that up due to a conflict of interest. But I too started out my career as an STNA in the nursing homes back in 1985, and sort of worked my way up through the care centers until I became a nursing home administrator and found myself here at the university teaching more students to be nursing home administrators.
All right. Does anyone have any questions they'd like to start off our panel with? Or like any questions about why anything about assisted living, nursing homes, and I know a lot of you are caregivers, any assistance with like caregiving and like how to feel you're making the best option?
I have a question, I think, for Michelle, right?
Yes.
I want to say Missy.
Yeah.
Can we utilize your assistance for palliative and hospice if my mother's in an assisted living facility now?
Absolutely. So palliative medicine is really care for the chronically ill, someone who has a disease process that is uncontrolled, that they need help managing their symptoms. That's what palliative is for. And it really, I kind of see that nurse as the quarterback or the doctor as the quarterback for all of the other specialists that are involved in that patient's care. What happens is you have many different specialists and their focus is primarily on their specialty. So you may have a patient who has congestive heart failure and maybe liver damage and having something else going on. And each of their focus is obviously on their specialty to really help cure or improve their quality of life. What doesn't happen sometimes is they don't all communicate. So you have all of these different medications that are getting administered, prescribed, and sometimes they're not communicating together, which we know that happens quite a bit. So as a palliative nurse, what they do is they're able to come in and kind of coordinate that care with all of their specialists and really try to alleviate the symptoms that the patient is having. The difference between palliative and hospice is when a patient is on hospice, they've made the decision that they no longer want curative treatment. They're ready to focus on comfort care, and that's what we focus on too. So it's really up to the patient what they decide to do. And if your mom said, hey, I think I'm ready to learn more about palliative medicine, we can do it in the assisted living, and we do it quite frequently.
She is terminal,
She is terminal, right,
so
right,
palliatives, you said chronic.
right, but she makes that choice. So she could continue on palliative, even if she is terminal. Or if she chooses, she could go on to hospice as well. And there's different criteria. You have to meet eligibility as well. But obviously, quite a bit about your mother. And so if she's terminal, then more than likely she would qualify for hospice care. The difference is that it's no longer curative, it's more chronic. So that's the difference. And I'd be happy to share a little bit more in length with you about that. Whenever someone has a terminal diagnosis, usually the lifespan that they're looking at for hospice is anywhere from 6 months to a year. But that can be longer. Some people go on hospice thinking they have 3 weeks to live, and they're still on hospice 3 years later. So that can change. And we see that a lot. I saw it with my own family member. January 1st, she went in and they were like, Michelle, she really needs to be on hospice. And so I'm like, okay, let's put her on. And we thought maybe she only had a few weeks, and she's doing great now. And she's been on it for 7 months. So I feel like, there's no specific way to, have a concrete answer about that. But I do think that it just varies depending on the patient, depending on the care that they're receiving, and depends really on her disease process. So,
Okay.
yeah, we come out to the home. We do what's called informationals with the family, so they can really be educated on what hospice is. And if the patient's eligible, we have a nurse that will review the case. And then what we determine is what's best for the patient and what her choice is. And also for the family. So hopefully that answers your question. Okay. Anybody else? Sure.
Yeah, so it makes the patient eligible.
They have to have a terminal diagnosis, and it has to be a certain stage for Medicare to cover it. And that's really what we're looking at when a patient is wanting to go on hospice, because Medicare pays for the care of that patient. They don't care for the room or pay for the room and board, but they care for everything else that revolves around that patient's care. If they need oxygen, if they need a hospital bed, a wheelchair, we want to provide that support and that care, the nursing care that gets involved in that. Nurse aides, they pay for that. It's a lot to go through, but that's really, you have to have a terminal diagnosis. And then it is reviewed by our nurse case managers to make sure that they qualify and that Medicare will cover, because that's really the goal, is we want to make sure that if we have a patient on our hospice service, that they're going to get that covered benefit under their Medicare plan. And it's certain criteria that we have to make sure that we're providing, or that diagnosis, in order to make sure that patient qualifies. Sure.
So is palliative care out of pocket then?
Palliative care is also covered under your insurance, but they're considered like a specialist. So you typically have a copay with that. And palliative care is typically, our palliative program, we go out in the community. There aren't too many palliative programs that do that any longer, but with us, it's your doctor makes a referral to our organization, and then we have a palliative medical director, and then we also have nurse practitioners that work underneath him, Dr. Saunders. And then what they do is they go out and see patients. And typically what happens is is, we get that referral and then we contact you to schedule an appointment and we go out to meet with you, review your chart, review all of your medical information, and then really try to figure out what's happening and why, the patient is struggling, depending on what the diagnosis is.
So what area do you cover?
We cover Northwest Ohio. We go all the way to Defiance, all the way north, well, north, not very far, to the Michigan line, but we go as far south as Findlay. Sometimes we go in Tiffin, and then we also go east to Sandusky.
Is Parkinson's a, what did you say it was?
Terminal diagnosis.
Terminal, yeah.
It depends on what stage they're in. And so that's something that we can evaluate, and we can pull records to determine the eligibility of that patient to find out. But yes, in certain cases with Parkinson's, yes, depending on what that patient's still able to do under their Parkinson's diagnosis, will determine how, if Medicare will cover their hospice benefit.
And then you would come in and shower them?
Under hospice, we provide, they only require, it's interesting, I know there's another gal who's in hospice here, but, under hospice, the requirement is one nursing visit every 2 weeks. We do way more than that. We see patients weekly, twice a week with an RN case manager, and then we also provide nurse aid visits. Now, we don't provide 24-hour care, but we do see those patients more frequently than a lot of hospices that I'm aware of. So, but if you're interested, I can meet with you after and we can kind of talk about that, okay? So. Any other questions? Sorry, I don't mean to interrupt, but
This is good. This is okay. Yeah,
Okay.
that's fine.
the conversation, but I'm happy to, I put my card in that folder that you all have. And you're welcome to reach out to me if you have specific questions about a family member or someone that you know or care about that you're interested in getting more information. I'm happy to talk with you further about that as well. So.
Thanks,
When-
Michelle. Oh, sorry. Continue.
When, I saw it in the paper to sign up for this.
Sure.
It talked about, where you can take somebody for a week so that the caregiver can.
Yes.
I would like to know a lot about
Okay, okay, so under, and you know, I'm glad that you brought that up because I was aware of something else that is, even if a patient isn't on hospice, there is a respite waiver through the area office on aging. And AJ, are you, do you?
Yes. So our second speaker after the panel will go over this stuff too.
Yeah, so that is an opportunity, and I'm anxious to really learn more about that for our patients that are on home health. And also with hospice, if a patient is on hospice, part of their benefit is that they're able to take advantage of a respite stay as well. Obviously, there's caregiver burnout, which is very, very difficult. And it's really hard on the family and the loved one caring for that patient. And under your hospice benefit, you can let our team know, say, you know what, I am just not able to do this. I need a break, or I'm going on vacation to see a family member. And then we coordinate having a respite stay with a local facility or a long-term care facility. And they assist getting that patient a respite stay. Yeah.
So with this caregiver burnout, all that, we'll transition into Angie to talk more about Brookdale. And I know a lot of things that caregivers think about is like, is it the right thing to like find somewhere for my loved one to stay? If you want to kind of discuss like when people feel like it's the right time and different things to look for and things like that.
Yeah. So obviously that's a huge decision. I should have prefaced or during my introduction, my background's in social work. I was a hospital social worker for many, many years. So I've had healers in all these different areas, home care, long-term care, hospice, all of that. And in those journeys, I've really learned that there's a lot of misconception about palliative care, hospice, assisted living, memory care, long-term care, just understanding what all those things mean. So for me, that was sort of my goal in being here today and helping people understand the differences in those levels of care. And I think we have, a lot of physicians that just say, oh, your loved one needs to go someplace, and then that's kind of it. And so my goal is to help people through that process, whether it's to my building or someplace else. And just to be a resource to people in the community. We want to partner with all the community agencies and help people get the services they need where they need to be. So in terms of that, making the decision as to when it's time, there is not a 100% right answer. There's no formula that we follow that says, right now is the time. There's things that you have to look at in terms of, quality of life for both your loved one and yourself. Are you truly able to provide the care that they need? When you think about someone moving into a community, you've got to remember that there's 5, 6, 7, 8 people providing the daily care. When your loved ones are home with you, it's you. Maybe adult child or two, or maybe a little help coming in here and there, but it really takes a toll on you. And then you are not only the caregiver, you're also the cook, the cleaner, the transportation person, the financial planner, the accountant, all those things. I mean, that's a lot. So, some of the questions I ask families, one of our first questions is always, what's getting harder? Why, when someone comes to me, why did you reach out to me? Obviously something is going on that prompted you to reach out to me. And even if it's, I'm not ready to do this, I firmly believe in making that connection with families and keeping in contact with people. Even if it's just a monthly check-in. How are things going? Is there something you need? Can I help you with anything? And referring to people like Michelle for home care or hospice, and Carrie back there is with another hospice agency. And having those relationships with other agencies and facilities in the community to help people get the services they need. Assisted living and memory care. So we've got, the differences between long-term care, nursing home care, assisted living, and memory care. And every facility is different. When we talk assisted living and memory care, I don't use the term facility. For me, it's a community. I know when we're talking long-term care, generally the term is facility, but it's a kind of a way to differentiate the two environments. But I feel very strongly that it is a community, and we are welcoming people into our family to have it be an extension of their family in a place where care is available 24 hours a day, whether they need it or not. It's available, it's there. But that is our role, is to help improve people's lives and make the time that they have quality time, and improve caregivers' lives and allow them to go back to being their adult children or their spouses or whatever the case may be. So I'm not sure if I really answered the question. I
No,
just
that
sort of
was
talked.
great, that was wonderful.
Anybody have questions about assisted living or memory care, or what that looks like, or? Wow, I didn't do very good. I don't have questions.
Well, a memory care
Mhm.
is what I think you emphasize on your company.
Well, we have both assisted living and memory care. It's two separate communities within our building.
Okay, and your building is where?
We're on Winter Garden Road, right by the Sunday station, Winter Garden and Worcester by the hospital.
Okay.
So we have a area in the front of our building, that's our assisted living, there's 47 apartments there. And then the back of our building is memory care, and there's 26 apartments there. So really, a lot of our residents do have dementia, memory issues, cognitive impairment. But we're there to support them and their families through that journey in whichever area they're going to thrive in the most.
So what are the differences between the assisted living and memory care based on like the services they're receiving?
Yeah.
Yes, yeah.
And this is a little bit of a hard one for me, because my building in particular differs from a lot of assisted living and memory cares in the area, in that we are uniquely equipped to manage the care of folks that have a dementia diagnosis, even a fairly significant dementia diagnosis, in our assisted living community. They don't necessarily always have to be in memory care. In fact, I will often say to someone, just because they're in memory care somewhere else, or someone is telling you they need memory care, we need to do that assessment to determine where in our building they would thrive the most, because our assisted living team is very well trained to manage those kind of dementia-related behavior type things, or just things that are unique to folks with dementia. And our whole building is secure, both in assisted living and memory care. So if someone is kind of at that beginning of, kind of getting over to the door and wanting to go home, and as long as we can redirect them and they're still able to socialize and thrive in the assisted living environment, they can stay in assisted living. And the reason I'm saying that is because in many other communities, once someone starts exhibiting that kind of inclination, they are quick to say, okay, we need to transition to memory care. And a lot of times it's a safety issue because of the secured doors. But we have the opportunity to allow people to stay in the assisted living environment a little bit longer. We're also able to accommodate a extremely high level of physical care, in that if someone needs and this is both in assisted living and memory care, if someone is so weak and debilitated that they are requiring the use of what's called a Hoyer lift, so if that's like an electronic lift to get in and out of bed or into the bathroom, it can accommodate that, or people who need two people to get them in and out of bed or to the bathroom, we can accommodate that. Special diets and help with feeding, we can do all those things. Many times you will hear someone say that if your loved one has those types of needs, that they need to go to a nursing home. And often that is the case, but our building in particular is able to accommodate those types of needs. Yeah,
Is your building part of the hospital?
we are not. No, we are a independent building. Brookdale's the largest senior living community or company in the country. We have almost 650 locations all across the country, but we're not affiliated with the hospital system. Anything else?
Well, respite care
Yes.
question.
Yeah, so we can provide respite at Brookdale, and most assisted livings can. Sometimes it's dependent on availability, bed availability. But we do not do it for a shorter period, it's gotta be at least 2 weeks. And really, a month is a little bit better in terms of the person acclimating, because 2 weeks, by the time they get used to it and get settled, then it's time to go home. So if someone is gonna come to us, we advocate for a month, but if it's only 2 weeks, we can do that, but we can't do shorter than 2 weeks. It's quite a process to make that happen, especially because our apartments are unfurnished. So when someone moves into our community, they bring in their own furnishings, and that's very purposeful. It's because we want that apartment to feel like their home. We want it to have the things in there that are comforting to them, that might remind them of home. And even if we think that maybe they don't realize it, there could be that one little thing that, subconsciously, they know it brings comfort to them. So that process is a little lengthy sometimes to get somebody in under a respite, but we can do it. We don't have anybody there under a respite right now. We have been running pretty full. But if we have the availability, we do. And then I'm always happy to refer to other get messages out to my colleagues who has availability, who's able to help accommodate that, to help lead people in that direction.
When you mentioned apartments, are they all in one building or is there? I've not been to Fostoria. I don't know what the name of that.
Good Shepherd.
Good Shepherd. And I have a aunt that lives there. So, but why does she live there? I mean, what help does she get from Good Shepherd that she has an apartment that's not hooked to the whole?
So she's probably in independent living, I'm thinking.
Yes.
So she may not be getting any help. She may just live there to be part of a community setting where if she would need help at some point, it's available. But often in independent living, it might be little to no help. But things might be included in terms of, maybe there's some I can't speak to Good Shepherd for sure what they include in their independent living. But sometimes it's the idea of being part of the system, to start out in independent living and then to be able to transition to the other location if and when the time comes. And that makes us a little different in the sense that no, we don't have those different levels of care, but as I spoke about being able to provide that really high level of care, people can stay. The goal is always that you stay throughout the duration of your life. We don't advocate for moving someone to a nursing home. I mean, unless they have to. But more often than not, people stay with us throughout the duration. Hospice comes in, palliative care comes in. Yeah,
Can they have a pet?
absolutely. Yep. We actually have, we have a bird, which I've never seen, but I've heard about it. I don't go in that apartment where the bird is. I believe we have a couple cats, and I know we have 2 dogs right now. We've got a little Yorkie named Millie, and we've got Deacon is like a Cocker Spaniel mix, I think. So yeah, we've got 2 dogs. Families can bring their pets in to visit. Yeah, so we've had a couple folks that have moved in that had pets before they moved in, and but can't really care for them. So the family members just bring them in to visit. But if someone lives with us and they have a pet and they're able to care for it themselves, we do not charge a pet fee. If they require our help to do that, then yes, we would charge them a fee. It's pretty unique. Most like charge a pet fee regardless of whether or not they're helping. So, yeah. So we love the pets.
Yeah,
Anything else?
all right, thank you, Angie. We will move on to Jennifer. We're doing pretty good on time. We're right about 11:30. So Jennifer, we'll let you start talking about your tips, details, what you recommend. I know you have lots of experience, so I'm sure what you have to say, there'll be definitely questions based off that, so.
So I guess the $1,000,000 question is, and I think Angie alluded to this as well, is when do you know is the right time to start looking at long-term
Yeah,
care
I got
options?
off track. I'm
I
sorry.
do that all the time. My students are always kind of like, okay, bring it back in.
Yes,
You went on.
Yeah.
And I've been a professional caregiver for, I don't want to do the math, but somewhere around 1985. And about half of that time I've been a family caregiver as well. And so I've cared for family members with dementia, I've cared for family members with cancer and with ALS. And let me tell you, being a professional caregiver is way easier than being a family caregiver. Because at the end of the day, you get to go home. Even when I was an administrator, I had a pager, I could phone a friend, I could call my DON, call other staff members. But as a family member, I'm in. And so, we do have some other family members when I've been a family caregiver that might be like, hey, can you come cut the grass? Or, hey, can you help out with a doctor's appointment? But at the end of the day, it came down to me, and for many cases, it came down to me because I worked in healthcare. So the rest of the family just kind of muddles along and then says, okay, you're it. And it's really a different family situation depending on how you're related. In some cases, I've been an in-law, so it's like, you're just an in-law. And then when they get into a pickle, it's like, okay, now you can come and help us out. Or, when I helped with my grandmother, didn't matter how old I was, didn't matter that I was a nursing home administrator, you're just the granddaughter. Until a crisis kicks in. And then, when it was my mother, it was like, no, I'm in charge on this one. So it's very different. And every one of those situations is very, my students hate it when I say it depends, but it really depends on the situation. Are you looking at just adult day services where, someone is still going to work, you have young kids and are still in school, and the person has help with or meals or things like that during the day? Are we talking about extra help, like Angie was saying, at the assisted living? Do they need help with bathing, toileting, dressing, grooming, that sort of thing? But the rest of the time, they're thriving, they're making friends, they're participating in activities, they're going on outings. How do you make those decisions? And when I talk to my students about Medicare, and we talk about Medicare a lot in the gerontology program, and I see my students at various intervals throughout their 4-year college program, and they say, but in this class you said this was the criteria for Medicare. In this class you said it. So Medicare is not Medicare. It's all Medicare Part A, but Medicare Part A, most people think about, pays for hospitals, also pays for skilled nursing care, pays for hospice care, in some cases pays for home health care. So it's a lot of, it depends, and what are the criteria? The criteria are not the same for each bucket that there is under Medicare. So you have to look at what does your Medicare look like? What are your supplements like? Are you in an Advantage plan? And sometimes it's just the financial situation, but for many people it's personal. For my husband, he promised his dad he would take care of his mom. And I'm like, oh, buddy, I don't think your dad meant this. And, we had round the clock caregivers at one point with her, and everybody's working and we all had kids. And in our particular situation, it came down to a crisis. And unfortunately, that happens with so many people. They're in a crisis situation. They go to the hospital, have to have surgery, or they're deconditioned, or, so many, they're dehydrated, different things like that. And then suddenly opportunities present themselves. So one of my situations, we ended up in the hospital, had to go to a SNF for some rehab because she was just so,
Jennifer,
needed.
what is a sniff?
Sorry, skilled nursing care facility. So we have long-term care facilities, we have nursing homes. And people think a nursing home is a nursing home, kind of like Medicare. Nursing home has skilled nursing care where people are there for a very short amount of time. And they're there for rehab and then they're going home. And then we have the long-term care side of the nursing home, which is where most people are staying probably for a very long time. And so that's different criteria, and Medicare does not pay for the long-term care side of things. It pays for the skilled nursing side, but not the long-term care side. So that gets a little bit tricky too. It's like, what are your family financial situation? If you have someone who was receiving rehab, but now the recommendation is for long-term care, does that person have Medicaid? Do they have the finances to stay there for an extended period of time? Or do we look at home health with companies that provide the level of care like Brookdale does? There's a whole number of it depends factors. And even with family, it just amazes me how we see people going home on PICC lines that have, maybe an IV and they're getting vancomycin every day that, we did in the hospital many years ago. We see people going home on wound vacs. Maybe they have vascular ulcers on their legs or different parts for vascular disease. It's, those are all things that we did in the hospital. And so for some family members, they go through training at the hospital and then the home health comes in and trains them again. Here's how you change your PICC line. And I'm thinking, nurses do that. Why do you want me touching a subclavian line? Or wound vac machines and things like that. But some people, they're just not comfortable no matter how much training. And, I've had family members tell me when I worked in home health, if I had wanted to be a nurse, I would have gone to nursing school. So that can be really hard for people. I've had family members when, someone else has fallen and I'm like, okay, come over here and help me pick, so-and-so up off the floor. And like, I can't. They just kind of freeze in that moment. So family members, every family member is created differently. Some are happy cutting the grass. Some are happy being all in and going to doctor's appointments. Some people are happy just bringing meals over. So it's a lot of, what does your village look like? And even having worked in the hospitals and nursing homes, and when I've asked patients or residents, what does your support network look like? And I can have a resident who has 11 kids tell me, I have no village, I have no social support network, and their kids are looking at them like, what are we, chopped liver? Of course you have a network, but then it also depends on that person. Do they feel like they're being a burden? They don't want to burden their kids. They don't want to, how proud are they? Do they want to ask for help? I've had other families who has one sole child and they're saying, oh, I have all the help I need. And that one adult child who's raising small children are like, yes, we've got this and we'll do it. But you can see that they're already overwhelmed because they're running to soccer and dance and everything else. And when my kids were growing up, oftentimes my husband and I had to sort of divide and conquer. I'm like, okay, I'm going to do this with the kids. You go do this with the parents. And then if it became a medical issue, okay, I'm going to go do this. And then you're going to go with the kids. And so it was sort of, how are we going to do this? And how do we divide up the work? And, I remember one time my mom, she passed from ALS. And the hardest decision in the world was to get my dad to understand that we needed hospice. And I remember we came back from the diagnosis and I told my dad, I said, let's start calling hospice companies in the world, in the area. And he literally pushed me out the door and locked it. So I'm like, okay, well, dad's not ready to talk about this quite yet. And so little by little, I would mention it as I was walking out the door. And then it was actually my mom who said, look, you need help. Not that she needed help, but we needed help. And she was ready and she'd also worked in healthcare and she understood what hospice and palliative and medical care was. And so she was the one who said, let's do this. And so at that point, we got to go back to being the spouse or the daughter. It got to a point where I would come in the house and I'd immediately start checking off this to-do list in my head. I gotta do dishes, I gotta do laundry, because my dad they had a home business. And so I'd be looking at all the things that needed to be done. And my mom one day, and with ALS, the speech is really tough. But it was like she was yelling at me like I was a teenager, and I got that look, and I got the voice, and I got the sit down and talk to me. And in my head, I'm like, I've got so many things to do. But she just wanted me to be with her. And so that was like, okay, that's it. We're doing it. Hospice is coming in to help us out. Sometimes, like, again, sometimes we have to reach that breaking point, but ideally, with what I do through optimal aging, and I'm sure like everyone else does with their marketing and outreaches, letting people know that these services are available. So many people have negative stigmas. You know, I joke about, we say the N word, we don't say nursing home, because so many people have misconceptions about nursing home. Most people don't realize nursing home is short-term rehab, and then let's go to another line of service versus extending into long-term care. Hospice is another one of the H word. You know, people don't like to say the H word, and a lot of people have a negative stigma of what hospice was. And hospice, my sister-in-law was on hospice. She was a cancer survivor for many years, and the family had to go to hospice, but hospice was also very different 40 years ago. The family would joke, she flunked hospice. Well, that's not exactly true, and that is definitely not the case anymore. So people just have these misconceptions, and so that's part of what we do with the Optimal Aging Institute, where I find experts in the faculty, whether it's myself or my colleagues or people in other departments, like how can we dispel these myths? And that's a big part of what I do as a gerontology instructor. I frequently teach a one-on-one level class, an intro class. And it's always fun to talk to the students, and I do this aging IQ quiz. And, you know, I ask them, you know, what percentage of older adults have dementia? And they'll be like, well, 100%. And, you know, then you ask them, what's considered old? And they go 50. And I'm like, watch it. Shit. Because, you know, and now that my kids have graduated from the university, at one point I thought I was hip and I was cool because my kids went there. And so I knew what they were going through, and they'd be like, yeah, nice try. Stay in your lane, professor. I'm like, okay, bye. So, you know, just trying to get them to understand, what does aging mean? And if I ask them what percentage of old people live in a nursing home, they're like, you know, probably about 90%. So that's when we kind of go into the, what does old mean to you? And then if I ask them, what age do you think you're gonna live to? They'll go 100. And I'm like, so at what point do you think you'll be considered old? And so it's very different perceptions. They'll be like, well, when I'm 80, then I'll be old. I'm like, but you just said 50 was old. So it's a lot of misconceptions. I love the students who have been family caregivers. They're a lot of fun. I'm kind of like, whoa, stop with the stories. I mean, I know I overshare with some of the stories, and that's my prerogative because I'm the grown up in the room, I'm the professor. But when the students start telling stories, I'm like, okay, whoa, this is personal information. Are you comfortable sharing this? Do you want your colleagues and your peers to know this? But you know, it's a lot of fun with the students and dispelling those myths. But even, you know, as an ombudsman and the ombudsman program, I'm no longer with the ombudsman program because I'm a member of the nursing home administrator board. But a big part of what we did was information referral. You can call the long-term care ombudsman office, and they will tell you about nursing homes. They will tell you about assisted living facilities after they've been surveyed by the Ohio Department of Health. Each nursing home gets at least one survey a year. Each assisted living facility gets at least one survey a year, you know, plus a few extras just for good measure there. And so they can give you the survey reports, and they can tell you verified complaints at those facilities. You can also go to Medicare.gov if if you like computers. And you can look at the 5-star ratings. Those can be a little bit deceiving. I don't know that the governor's task force would like me saying that, but a little bit yeah, they can be a little bit confusing sometimes, because you can see this facility has a high rate of, you know, certain medication uses. But what you don't understand is that this facility works with people with cognitive impairments, or maybe older adults with psychiatric illnesses, mental health issues. So they might have a larger number of medications used to treat those illnesses than, you know, what somebody else does. You could have another facility who specializes in wound care, but their 5-star rating is going to say high number of wounds in the facility. So some of those things you kind of have to balance out with looking at the 5-star rating, looking at what the resident satisfaction scores are, and then also, you know, kind of pouring through those facility websites. And, you know, I have to stop saying facility myself, because that is something that's going into is going into effect soon at the national levels, taking away the name nursing facility to nursing community. So I have to keep correcting myself, like, not facility, community. Really trying, and when I grew up, some of you may know Lake Park. Used to be, well, still, the building is still standing next door to Flower Hospital. That's where I grew up. That's where I became a nurse today. That's where I worked in physical therapy. I did my internship to be an administrator there. It was a 300-bed facility. But when I walked in that building in the 80s, white hallways, white floors, I still wore white scrubs, white shoes. I had a DON who made, she's checked our shoes every day to make sure we didn't wear them outside and stuff. Remember that stuff you used to use to clean your kids' baby shoes? Yep, we did that on the soles of our shoes just to make sure that our soles were clean. So that was a very different environment then. It was very medically oriented, but long-term care has come a long way since over in 1987. And it's taken a number of years since 1987 to get us to a more person-centered environment where you can walk into care centers and they're warm and they're inviting. You don't see people in restraints, and if you do, you should probably call the ombudsman office on that one. You shouldn't see people parked at nurses' stations, and you just shouldn't. So it's a much different world now. Even I worked in care centers that were 4-bed wards at one time, and it was a four-bed ward that shared a bathroom with another 4-bed ward. And when I tell my students that, they kind of go, "What's a ward?" Like when I tell them I used to have a beeper, and they're like, "What's a beeper?" My cell phone, but attached, and you couldn't talk to anybody, it just made lots of noise. So they're very, very different now. Actually, the 4-bed ward facility that I used to work in has been transformed into an assisted living facility now, and now they're all single rooms. So it just amazes me when I walked in there as an ombudsman, I look at the place like, this is not my old building. So it's much more warm and inviting than what the nursing homes that a lot of us think of when you're thinking.
I just want to know, well, what exactly is an ombudsman?
The ombudsman works as an advocate for residents, family members. They don't take sides. So you have the Ohio Department of Health that comes into the facilities at least annually, comes in and visits and does what they call a full book survey. They walk in, kind of flash a badge and say, "I'm from the Ohio Department of Health." They have access to everything to make sure that it's clean, that the residents are happy, make sure that meds are being passed appropriately, care is being given appropriately, people are getting the proper amounts of PT, OT, and speech therapy. The ombudsman kind of works in conjunction with the Ohio Department of Health, especially when it comes to if there's a lot of complaints from the particular care center. So the ombudsman is someone that you can call and they work for you. They are your advocate. And so a lot of times residents in care centers may call the ombudsman, and the biggest complaints are usually call late answering, and food. And so, that's sort of to be expected, but a lot of times when I would go into the care centers as an ombudsman, people just wanted someone who would listen to them. A lot of times I didn't have to do anything other than to be an ear. If there was something, and I have to have their permission, if the person tells me about this aide is mean to me, like, do you want me to do something? Because if they tell me, no, I just wanted you to listen, I can't do anything. But if they say, yes, I want you to talk to nursing, I'm gonna try and talk to that resident and say, why don't you come with me? And we'll talk to them together. A lot of times as an ombudsman, I would go into the resident council meetings. And of course, the resident council meetings are supposed to be for residents only. A lot of times they're driven by the facility social worker or the activities director because somebody has to get them all down and together. But if they've elected a resident council president, they have the right to kick that person out. And then everybody else that comes in has to be in by invitation. So even as an ombudsman, a resident has to invite me to attend their resident council. And sometimes they just want someone to explain things to them. Sometimes they want to vent a little bit. Sometimes they want someone to explain. And unfortunately, the staff don't always have the time to explain why they're doing things or what they're doing or how it's going on. And so that's kind of the role of the ombudsman. Let's do some education. But if there's a concern, we're going to help empower you to go and help you advocate for yourself. But if you're not comfortable doing that, then that's what we do. We will go and talk to whoever we need to, whether it's a therapist, the administrator, the director of nursing, or whoever.
I had a question when I heard you say that if they're parked by the nurse's station, it's a sign of something wrong. Because my dad died in 1992, he had dementia with Parkinson. He was in a Good Samaritan home in Northeast Iowa for 2.5 years before he died. When he first went there, they had him sitting with a belt on, so he couldn't stand up. Then the law changed so that they couldn't have a restraint. So they put him in a recliner and put him near the nursing station. So if he started to get up and
Mhm.
probably couldn't, but Abe knew sometimes he was able to more than you would have thought.
Right.
So what is the answer?
Um, I think that's still sort of a work in progress. And like I said, when I began in the eighties, that's what we did. We had lap belts, we had posy restraints. And we thought we were doing what was best because we didn't know any better. And then some laws changed, we would park people at the nurse's station because, there were Houdinis. They could get out of those restraints no matter how they were put on. And then some laws changed in 1987. And then we started to find alternative ways to care for people. So we had seat belts. And it wasn't considered a restraint if they could take the seatbelt off. For a lot of people who may have had a stroke, because they may have arm affect. And we don't just want that arm hanging there because it will swell up. So we started putting tray tables. And then that became a restraint because the person couldn't remove it. Jerry chairs, the big reclining chairs, those are considered restraints if the person can't get out of it. Then we started, we kept coming up with new and more innovative ways. We started using tabs alarms, where we would clip something to the back of their clothing, or we would put pressure alarms underneath their bottom. And so if they tried to get up, it would emit this awful ear piercing noise. We actually found those to be a restraint. There was a number of studies done, especially and tabs alarms. Not only did it damage your clothing, actually increasing, so afraid to move. Like if I shift, if I squirm, if I do whatever, that alarm is gonna go off. So we found that they were just sitting still. And I went into one room as an ombudsman and I said, would you like to go out? After we finished talking, I said, would you like to go out to the dining room? Would you like to go out to the activity? She says, no, if I move, they yell at me. So tabs alarms, pressure alarms, not necessarily the best option for a restraint. Restraints can be used in very rare situations now, but still, we still gotta keep working, working on those.
Because we want him to be safe. I mean,
Right.
we want my dad to be safe. We thought he was at every stage. And when you said not at the nursing station, well, hey, they were aware if he was trying to get up. I don't think he could have, and I don't think he ever was able to, but they were watching, which we were glad of.
Just to kind of piggyback on what you said, so in our particular community, one of the things that we really focus on in memory care is really upping that resident engagement, so getting people out of their apartments into the common areas and participating to whatever level they are at. We might have someone there performing music or something, and some may be sitting there clapping, singing along, others may just be sitting there. But they're out in the common area, all the staff is there, so there's just a lot more of that hands-on, eyes-on, but not necessarily like I think what you were referencing is like the person just slumped in a wheelchair
Yeah.
asleep, out in the middle of the hallways. We do try to not have that, to try to get people as engaged as we can. I mean, obviously, at some point in the disease progression, that's just kind of where they're at, as as they get closer to the end of the progression of the disease. But we really strongly believe in that resident engagement and finding ways to keep them as active as possible and engaged in their environment to help prevent, we're never gonna promise somebody that their loved one's not gonna fall, but we're gonna do as much as we can to prevent that. And then also, within our licensing and limits, but even things like in their apartments, we lower beds to almost to the floor, because we can't have rails. That's considered a restraint, so we would lower a bed very close to the floor. We can use like almost like those little play mats, the foam things on the floor next to the bed. We use wedges in the bed to push up against it, so they're less likely to roll out of bed. And sometimes the bed's like up against the wall on the one side, so just different things that we can do to try to keep them as safe as possible. Does that make sense?
With timing, we have time for about 2 quick questions, if anyone has any last minute questions, and then we'll wrap up for lunch and then get into our next
I
presentation.
do have one more thing I just want
Yes,
to say.
yeah, of course.
Real quick.
Yeah.
So in an effort to invite you all to come to Brookdale if you'd like, just to check us out and take a tour. We are doing a little grab and go meal next Thursday from 4:30 to 6. no commitment, you just would sign up and come in and say hello to me and I'll give you your meal to go. If you wanted to take a tour, you can. I'm gonna put these little sign up slip at the back table, give it to me, and the number there for me. And then I will call you like on Monday or Tuesday next week to confirm that you still want it and go over the menu with you. We're having, it's a summer menu, so black bean and corn salad, turkey burgers, bratwurst, potato salad, and applesauce cake. So if any of that sounds good, fill out one of these little slips for our folks in the room, and I'd be happy to have that for you. Thank you.
Nancy, yep.
This is a quick one. What happens if a person really can't be handled by the family at home, but they refuse to go to leave home?
Who wants to answer that one?
Well, we experience that a lot in home health. Patients are very resistant to want to be able to leave their home. So what we do is we collaborate with a lot of private duty care agencies, since we only provide skilled care. And so with our home health, we have social workers, staff, and they work with private duty care and they kind of coordinate when we're going to be there, when that private duty is going to be there, and try to coordinate with the family too. So that way then it relieves some of the burden off the family, but provides the care that the patient needs at home or the loved one. And we've been pretty successful with it. In certain situations, we know that it's an unsafe situation, so we have meetings with the family and then we bring in maybe a assisted living like Angie's place or with another organization and to placement. So we bring them in as well too, so they can assist. That's a really good resource that I think is underutilized, but oftentimes it can be, I know in the Lucas County area, it sometimes can take a while. But I definitely encourage you all, if you're thinking that you need to look at like alternative placement or, considering, a waiver or things like that, to really reach out to your area office on aging. They were a big help to me with my mother-in-law. So.
Thank you. Yep, last question here, Doris.
To take couples in this, these
Assisted
situations.
living? Yep, we have a couple couples right now. Yeah, and then we actually have a situation where we had a married couple that lived together in assisted living, and they both have some dementia, but one was worse. So she just moved back to memory care and he is up front, but they can see each other as often as they like.
Okay.
All right, thank you, everyone.